Hello again. Thank you, Dr. Reem, for your very interesting lecture. I think we can start now with the questions, and we can start with the first session. It was about COVID, and I think we have here a question, which is, I think, everyone is asking now. Dr. Ibrahim, one question is coming to you, stating that if I want to take a vaccine, which one is the best?
Okay, this is a good question. We have different vaccines now, even from AstraZeneca or Pfizer or Russian vaccine or Chinese one. The best one, according to our last clinical trials, which is done in 57357 by the research team, is the AstraZeneca one, because depend on our research, we make a gene code for our virus, and we found that the virus is like about 97% from the virus, or the gene code of the virus of COVID-19 in Egypt, which has come from England, and the AstraZeneca vaccine, which is dependent on this gene code.
Okay, I think the next question is speaking about the post-COVID syndrome, and what is the problem of the post-COVID syndrome, and how can pharmacists help in managing post-COVID syndrome? Okay, please, Dr. Ibrahim.
Thank you, Doctor. About the post-COVID syndrome, we have a lot of problems. Like we found that many of diseases or many of conditions, medical conditions, found after wave 1 and wave 2, and now in the wave 3, it's about like a depression. It's the main one. We have many of our patients suffering from severe depression after infected with the COVID-19. Some of them like have a problem in the smelling and taste, some problem in the headache, and some of our patients is with the diabetes, which is maybe dependent on the corticosteroid doses which are given in the protocol. And we must to manage about all of these medical conditions by the rule of clinical pharmacist, by adjusting the dosing of medications, minimizing the side effects, and avoid drug-drug interactions. This is found mainly in the elderly patients, which is taking a lot of medications, and due to the drug-drug interactions, we found that the side effect or the post-COVID syndromes may be elevated and maybe complicated in some cases.
So, Dr. Noha, do you want to start with questions for the session 2 regarding kinetics?
Yes, Doctor, I have a question for Dr. Rami from the pharmacokinetics point of view. Do you think is there a difference in the pharmacokinetics parameter between subcutaneous and IV administration of GCSF?
Oh yes, it's a very good question. After administration of the GCSF, the absorption obeys both zero-order pharmacokinetics and first-order pharmacokinetics. The elimination starts by after binding of the filgrastim to the GCSF receptors, and this clearance appears after the binding that appear very rapidly after administration. In both subcutaneous and IV infusion. However, the main difference between the two routes of administration lies in how far this process, how quickly this process occurs. In IV administration, the peak concentration is higher than in subcutaneous. The rate to reach of the speed to reach the CP or the Cmax is higher in IV more than subcutaneous, and the systemic exposure in the subcutaneous administration is quite higher than IV administration. This is the main pharmacokinetic differences between the two administration ways of GCSF.
Thank you, Dr. Rami. Dr. Sherif, would you like to ask?
Okay, I think we have some questions for for the session regarding the OR clinical pharmacy. So Dr. Ibrahim, there was a question about, we always in the OR speak about the surgeon, but the anesthesia team, what is the interaction pharmacist anesthesia team? And also another related question, if there is any drug that need to be prepared during the operation, including anesthesia medication, what are you doing?
Okay, thank you, Doctor. About the working with the anesthesia team, it is very important inside the operation room, because the anesthesia team is the main part of the medications inside the operation room department, and we must to make a good relation and a good correlation with the anesthesia team. Our work is like about drug information for the team, because we are updated about the medications. We are the drug experts inside the OR departments. So we have to be updated with the most of the medications about drug-drug interactions, about the side effect, about the dose modification. If we have any dose modifications, there is no compare between the anesthesia and the work of clinical pharmacy inside the operation team. We are working as a one team. And about the medication prepared during the operation, we have a procedure like if we need stat medications inside the operation during the operation, the consultant or the anesthesia consultant must check the checklist about the medication needed inside the operation room, and the OR clinical pharmacist can prepare it in like about 3 or 4 minutes by maximum, except in if we have cardiac arrest inside the operation room, the rule of preparation give to the anesthesia nurse under supervision by the OR clinical pharmacist.
Thank you, Dr. Ibrahim. Dr. Noha, you can ask for the final session, the genomics.
Okay. For Dr. Reem, there was a question from about the pharmacogenetics. How can we use the pharmacogenetics in predicting prognosis?
Good evening, everybody. We can use pharmacogenetics in many options and in many predictive methods. Mainly in my mind right now, two options or two circumstances. First of all, in pediatric and adult gliomas, those who have methylated MGMT enzyme have better prognosis from temozolomide use rather than those who are with unmethylated MGMT enzyme. And in cases of lung cancer as well, those who have EGFR mutation, T790M mutation positive, this predicts failure for the use of erlotinib, and it makes us to go through the use of osimertinib. While if it is exon 19 deletion or exon 21 insertion, it gives us the opportunity to start with the first line erlotinib, and to leave the osimertinib to be the second line for the use, or in case of CNS metastasis. So pharmacogenetics gives us these options.
Okay. Thank you so much.
Thank
Dr.
you.
Sherif, you can close the session.
Yeah, thank you very much all, Dr. Reem, Dr. Noha, Dr. Rami, and Dr. Ibrahim. Thank you very much for your contribution. It was great today to see how the scope of pharmacists and how clinical pharmacists can be very effective from the starting in the even proactively, like Dr. Reem was speaking about pharmacogenetics. Dr. Rami spoke reactively about the therapeutic drug monitoring and kinetics. Dr. Ibrahim spoke about how pharmacists can initiate and open scopes in new services like the OR. And we also, all of us, saw how our pharmacy heroes were dealing with COVID-19. I hope that we will continue this hard work together and build a cohesive team to cure our patients and to have childhood without cancer. Thank you very much for all of you, and I hope to meet next year in the beautiful Alexandria, but face to face.
Virtually. Yes,
Sure,
I hope.
Sure. Thank you. Welcome, everyone.
Thank you, Doctor.
Thank you, Dr. Sherif. Thank you, Doctor.
Thank you and goodbye.
Goodbye.